Welcome back, everyone, to Pulm PEEPs. Furf and I are so excited to be back together. We're kind of right now in the middle of summer, so hope everyone's enjoying their time. I think it's such a special time in the hospital. There's new residents, there's new fellows, so much excitement. So excited to bring you, though, a new case today and get back with things.
Yeah, I love this time of year. New interns, new residents, new fellows. I feel like everyone has really great questions. And then the questions often let you teach about some core physiology or core topic, which is great. But they also then sometimes for topics that are a little more nebulous, make you really go back and say, what do I understand about this and what don't I understand? And so actually we're going to talk today about a topic that is one that I think is pretty poorly understood, but also extremely important and basically ubiquitous in any ICU where you're going to be practicing. So we're going to be talking about ICU acquired weakness today and hopefully drill through some of the uncertainty and get down to some of the misconceptions and some of the facts that we can understand about this to help take care of patients.
Yeah, and we're very excited to welcome our guests today. We have two special guests. We have one returning, and then we have a Pulm PEEPs first today, where we're thrilled to welcome our first Physiatrist. And for those of you who may be asking what a Physiatrist is, that's a healthcare provider specializing in physical medicine and rehabilitation. But our first to the show, an honor to welcome Dr. Jim Devanney, who's a Physiatrist who just completed a neurocritical care fellowship at BIDMC. He's currently transitioning to a clinical associate position at the University Health Network, University of Toronto, where he'll be working as a PM&R consultant within the ICU. Jim, such a pleasure to have you on. Welcome to Pulm PEEPs.
Thank you, Christina. It's a pleasure to be here.
Yeah, thanks, Jim. We're equally thrilled to welcome back Dr. Kalaila Pais. Kalaila works at Bethesda Deaconess. She's now a third-year senior medical resident, interested in pulmonary and critical care and medical education. She's done some great episodes with us in the past, and we're thrilled to have you back.
Thanks for having me. It's always great to be back.
Absolutely. And just as our standard disclaimer, as a reminder, this podcast is not meant to be used for specific medical advice. The views we express today may not reflect those of our respective employers. And the case we will present today is HIPAA compliant. Any details or patient identifying facts may have been changed to protect the privacy of our patient.
Thanks, Furf. And Kalaila, welcome back. As Dave mentioned, I feel like you're almost a Pulm PEEPs veteran and love doing some partnering with you, some recent Core AM projects. So really love the collaboration that we've had with you so far. Excited you're a senior resident now. I feel like the leader of the team, the know-all. So excited for your year and your growth. And you actually brought this case to Dave and I to discuss. So thank you for this opportunity. And we're hoping that you can start out today by just describing how the patient presented to you.
Yeah, of course. It's great to be here. Thanks, guys. So let's start with the case. We have this 65-year-old male patient. He has a history of hypertension and type 2 diabetes, and he was initially admitted to the ICU because of severe sepsis secondary to a pneumonia. So he was mechanically ventilated, he was placed on vasopressor support, and he even got Cape Cod dose steroids. And then after about 2 weeks in the ICU, even though his septic shock had improved with IV antibiotics, he was still having this profound generalized weakness, particularly in his proximal muscles. And we were having a hard time weaning him off of the ventilator, and it was already day 14. His vital signs were otherwise stable. He was breathing at 100% on the vent. And his physical exam was most significant for this profound symmetric limb weakness, more so in his lower extremities. His deep tendon reflexes were intact, he had preserved cranial nerve function, and we didn't see any sensory deficits. So this patient came in for sepsis, has gotten better from a sepsis point of view, and now his primary issue is more so weakness. So Christina, when you're taking care of these patients, what are you usually thinking about? How are you usually approaching it?
Thanks, Kalaila, and thank you so much for the question. And you brought up some great things already that we should be thinking about. Just duration of hospital admission. So you mentioned 2 weeks. Other comorbidities you mentioned, as well as coming in with sepsis and getting steroid dosing, as you said, kind of the Cape Cod protocol. So some things that we should be considering. But when you're thinking about an approach to weakness in the ICU, I know there's many frameworks that you can think about, but one that I like is really going from brain to muscle. So a neuroanatomical and system-based framework for thinking about weakness in the ICU. And as I said, the idea is to work from central to peripheral, so brain to muscle, to systematically consider where along the motor pathway the problem could be, because it could be so many different places. And I think one thing when you start to have a broad differential, you kind of start just naming potential etiologies. And sometimes for myself, if I do that, I get a little bit disorganized and may miss something. So I really try to do systems based. So this could be starting with the brain and spinal cord, then moving to the anterior horn cells, the peripheral nerves, the neuromuscular junction, and finally the muscle itself. So as I said, I think it breaks down things in a way that's organized and practical. So you're not just listing diagnosis, but really thinking about them on the level of dysfunction. And I'm sure we'll get to hear from you and Jim and Dave in a bit just on other ways to think about this and the important tests and diagnostics that we should consider. But to think about this more broadly, going through the system from a CNS standpoint, I think some etiologies that probably those listening today are already considering, right, is any trauma that the patient may have experienced, any recent hemorrhage or infarction that could have occurred, as well as potential infection. And this is going to be broad, but such as encephalitis, potentially new abscess formation. This is where we can think about myelopathies as well. Subclinical seizures is also very important. And then a topic I'm sure we'll get to is just always having delirium as part of this etiology for the overall brain and CNS. So after I think about the CNS and think of those etiologies, I really then move to more of the anterior horn cells, where this could be more motor neuron disease, poliomyelitis or West Nile virus could be considered in this. Moving from anterior horn cells into peripheral nerves, thinking about Guillain-Barré syndrome, as well as several neuropathies. And this could be more from a vasculitic component, a perineoplastic component, or really critical illness polyneuropathy that you should be considering. Moving from peripheral nerves, I'll then go to the neuromuscular junction. So thinking about myasthenia gravis. I work with a lot of oncology ICU patients who may be on checkpoint inhibitors. So sometimes you can get a myasthenia gravis-like effect from checkpoint inhibitors to have on your differential, but also thinking about Lambert-Eaton syndrome, botulism, or any neuromuscular blocking drugs. And then from neuromuscular junction, as I said, going to muscle last. So thinking about etiologies such as inflammatory myopathies, such as polymyositis, as well as dermatomyositis. Rhabdo definitely should be considered. More rare cases, but you should still have on the differential could be some mitochondrial myopathies. More common cases to think about in someone who's been hospitalized for 2 weeks could, drug-induced or toxic myopathies. And then we always have to think about critical illness myopathy. So I know a lot of things were just said, but again, I think if you could remember and take away from today, just go from brain to muscle and be system-based. I think that could at least help you think of good differentials. But based on the differential FERF, right, lots of things to talk about today, but what kind of patterns do you associate these with and what could we be looking for?
Yeah, so I think weakness is such a broad term, right? And then we're starting to try to hone down on it. And you don't have to know and be an expert on all these things, but it really does help you to have a framework to think through it. It also helps you frame a good question for your consultants, which will include everybody from neurology to your physical therapist, to your physiatrist like Jim, who are going to come in and give an evaluation. And if you can really have a picture that's well described, that can help everybody. And so I also take that same anatomic approach. And then Kalaila already did a really great job of adding some of the things that we are going to be asking about. So the first is this symmetric or asymmetric weakness, right? Asymmetric weakness, I really start thinking about central nervous system problems, upper motor neuron problems, because everything else should likely affect the nerves, the neuromuscular junctions, the muscles in a similar way. And so asymmetric really gets my warning signs coming up about whether or not I have some acute CNS process that might need to be an evaluation. So some patient tells me they all of a sudden can't move their arm. Obviously, it could be a peripheral nerve compression, but my first question is, do I need some head imaging for a central stroke going on? The next thing that I think about is the pattern of it. Is this sort of proximal versus distal? Now, this I always find frustrating personally because everything has an atypical presentation, right? So even the things that we think about as being really like a distal, where it's really like Guillain-Barré syndrome has this sort of ascending distal weakness that comes up, you'll have that atypical case that comes in where somebody just starts with a respiratory failure phenotype. And so I do like the patterns, and I do gather that information, but obviously you have to keep in mind that there can be atypical or common presentations of common diseases. But some things are like really textbook. So like myositis really are going to be a weakness in the proximal muscles, the deltoids, biceps, triceps, the quadriceps and hamstrings, and the lower extremities. And so those things usually follow that typical pattern. So I want to get a sense of that. Sensory loss, really, a lot of these conditions distal to the anterior horn cells really shouldn't have sensory involvement unless you have mixed neuropathy. So that always raises something in my head about, okay, I'm not really thinking about neuromuscular junction or the myocyte itself. If I have combined sensory loss, it's got to be the mixed nerves or above that are carrying this. And then I care about reflexes as well, is that a little bit of that same distinction. Anything that's neuromuscular blockade or below neuromuscular muscle should have that preserved circuit, even if something centrally is going on. And so if I have preserved reflexes, I'm really thinking more distal in that central nervous system down to myocyte distribution. And if it's got a change in reflexes, hyper, areflexic, then I'm thinking more proximal to that. So these are the types of info I get. We're going to post a graphic and an image to show some of this. So you can see where all of these conditions lay out along that spectrum. And I won't talk through each of them right now because that would be a pretty boring podcast. But Kalaila's already given us some interesting information that this is a patient who has this going on. It is symmetrical. It's in the limbs, more in the lower extremities. So we could think about some more like ascending patterns. We have preserved cranial nerve functions, no sensory deficits, or we're thinking a little bit less of the central nervous system, and we're really thinking a little bit more distal in the nerve sheaths, the neuromuscular junction, the myocytes that might play a role here. So we're going to have to get a little bit more detail and a little bit more studies for sure. So Kalaila, can you tell us what else was obtained and what were some of the next steps in the workup for this?
Yeah, so the patient's labs were mostly unremarkable. He did have an elevated glucose in the 300s, a mildly elevated CK to 465, but a normal CRP and a flat lactate. We got imaging of his brain, so brain MRI, CT head. Those didn't show any acute pathology. And then he did finally get an LP, which was also unremarkable. So normal protein, normal glucose, normal opening pressure. And then on exam, we still didn't note any deficits to his cranial nerves. And there was no fluctuation in his weakness. So it didn't get worse like with repetitive motion, like better with repetitive movement.
Thanks, Kalaila. Yeah, I think this is really helpful and brings us to these next step for the workup for these patients. So we talk about these broad differentials. And now, as you're giving more info, we're seeing how this presentation is probably going to fall into this broader spectrum of ICU acquired weakness. And we'll talk about the components of that in just a second, thinking about myopathy or neuropathy. But he has all the classic signs. He had severe sepsis. The timing kind of came on after that. He has generalized symmetric proximal greater than distal weakness, which we see. He has reflexes that are present, and that makes us think less of when we're absent. Over time, you could get decrease in these reflexes. We don't see any cranial nerve lesions. That's really important. We don't think there's going to be like a focal deficit. And we've had a really good workup of the central nervous system now. We're less concerned about infections. We've had an LP to be really thorough about this. The CK is mildly elevated. If it was in the 20,000s, we might be thinking more about a rhabdo or more about like a severe inflammatory myositis picture, but it's certainly very common to see low-level elevations like this. And then importantly, in ruling out some of the things like we don't want to miss, electrolytes are pretty much normal, is what we've heard. The labs are mostly normal. Glucose is a little bit elevated, and we'll talk about that. But that's just something we're going to have to control. And then I think everybody in the ICU also wants to maintain awareness of these types of conditions that are really treatable and reversible. And so like Guillain-Barré syndrome is one of these. After an infection, you can get this progressive weakness that then ends up leading into areflexia and respiratory failure. The LP being normal with normal protein really makes us feel more reassured about that. The timeline seems more like an ICU acquired weakness, but so it just moves much lower down our differential. And so we're probably not going to worry about it. And then some of the other conditions that we always want to be wary of and think about like in med school are like myasthenia gravis, Lambert-Eaton. You said cranial nerves are intact. There was no fluctuation of the weakness. there was no weakness preceding this presentation. So I feel a lot better about ruling these out. I don't even usually have to send the testing for these unless I see some like red flag symptoms. So I think this really helps us thinking about the ICU acquired weakness. And then, yeah, Jim, if you could move into summarizing some of these findings, how you think about it, that'd be great.
Yeah, absolutely. So importantly, we took that very broad system-based approach going proximal to distal and really worked down that list. So as you're talking about now, the CT, MRI, everything being clean, it doesn't fully rule out anything central. Of course, there hasn't been a EEG done. However, that's not something that generally just presents as only weakness or anything like that. And so that helps me move away from just a focal seizure, focal status or something in that nature. The big thing with this patient that we discuss and how he presented is he presented with a significant illness, no weakness. And so the important thing is ICU acquired weakness as an entity needs to have started after the onset of critical illness. It can't have to be something that preceded it. Of course, somebody can be weak and then develop ICU acquired weakness, but they're two separate processes. And so the timeline for this patient really help us focus on this diagnosis. And as we've discussed as well, generalized weakness is showing something more systemic. It's not showing that there's focal compression in the spinal cord. It's not making you think that there's something in one certain location to go after. Overall, the picture that we've shown and demonstrated has this person that is at high risk of acquiring ICU acquired weakness for reasons that we'll talk about later, and presenting as if he has it. Importantly, and we'll talk about this later as well, ICU acquired weakness, it sounds like a unifying diagnosis. However, it's an umbrella term. It describes different entities, specifically critical illness myopathy, critical illness neuropathy, and then the combination where both are present at the same time, critical illness neuromyopathy, which all have different pathophysiologies within and all present in a similar fashion.
Yeah, absolutely. I think this is one of the issues, and with ICU acquired weakness, as you said, is it really is this umbrella term. And importantly, why are we talking about this? And it's because we know that ICU acquired weakness, a patient just like this compared to a patient who had the same illness but doesn't demonstrate these findings, really has large impact on their outcomes. And these are both short-term and long-term. Like, it's very clear that patients who have ICU acquired weakness compared to those who don't have longer stays in the hospital, longer time on the ventilators, increased likelihood of being re-intubated, increased ICU and hospital mortality as probably a consequence of these other short-term consequences. We also know that if you leave the hospital and had with still some level of ICU acquired weakness, like depending on what functional level you achieve, you're more likely to go to rehab than home. You have long stays at rehab, and that's associated with its own side effects. And you actually have an increased chance of coming back to the hospital. And then decreased functioning at a year in this world where we're really focused on post-ICU syndrome. And you guys can listen to our episode that we did with Dale Needham and Wes Ely about this. This is a huge component of that. Patients a year out who just can't do what they used to after an acute illness. So we care about finding this quite a bit. Jim, you sort of mentioned that the pathophysiology is not unifying, right? Because there's multiple different etiologies that can be lumped into ICU acquired weakness. Could you tell us a little bit more about some of the factors that do go into developing this?
Yeah, absolutely. And I think just before moving on to that, I think it's such an important connection to make with ICU acquired weakness and post-intensive care syndrome. And just, there's not something that says exactly ICU acquired weakness becomes post-intensive care syndrome, but you can definitely infer somebody who's weak and continues to be weak for a year following intensive care stay that significantly impacts their life and can, of course, impact all the other domains of PICS. So jumping into critical illness myopathy, as you can tell from the name, myopathy has an issue within the muscle itself. And so the pathology is primarily, in this case, related to muscle. So with this, there's a selective loss of myosin, or the thick filaments. It's unclear exactly why the thick filaments are preferentially impacted. However, it might have something to do with a bioenergetic failure, as the myosin is what connects with the ATP to help the contraction happen. Within that, the type 2 muscle fibers are most frequently associated or are most frequently affected. So these are the fast twitch powerful fibers. So you can imagine the significant weakness associated with that, as opposed to a slower filament that would be less visible on exam. Additionally, with some of the damage to the muscle, there's impairment of electrical impulses with inactivation of sodium channels, which can happen with acid-base changes as well as other changes within the muscle itself, resulting in a decreased excitability. All of this is also coupled with bioenergetic collapse, as I talked about with binding to ATP on myosin. Mitochondria is less functional in the state of critical illness, especially within sepsis and other things that we'll talk about in just a minute. And of course, this all results in an impaired functional outcome. Now, moving to critical illness neuropathy. Now, this is a nerve issue specifically. And so there's injury to the nerve itself, usually the axons. One proposed reason is by microvascular dysfunction. And so there's a decreased perfusion to the nerve axon itself. So that can result in ischemia, altered permeability, changing of the lining or the myelin sheaths that help to propagate the electrical impulses quicker. And then with that, you can have degeneration of the axons. And so this is really helpful in differentiating the physical exam findings that you see with these patients and how there can be some variability in presentation. However, importantly, this is a continuum. They can happen together. Critical illness myopathy, critical illness neuropathy. They can become something called critical illness neuromyopathy or polyradicular neuropathy. And so these are things that are important to differentiate, to try to look for in the patients that you see. Importantly, as you're having somebody with a more neuropathic picture, if the nerves themselves are damaged, you can have more of a distal pattern. As you can imagine, damage to the nerve, then along that track, as with a radiculopathy or something of that nature, the more distal things are more frequently affected and longer to recover. Things to discuss, as we've alluded to earlier, for pathophysiology reasons why this happens. There are both modifiable and non-modifiable risk factors, starting with hyper or hypoglycemia, which we've seen in our patient. High sugars are injurious. They can result in reactive oxygen species formation and then damage for so many different reasons. So it's important to have a good control of sugar. However, as we've seen, or as multiple studies have shown, over aggressive control of sugar can also be incredibly damaging as well. And so having that general 140 to 180 goal of blood sugar is important. Parenteral nutrition can be a risk factor. You want to start with early nutrition enterally as possible. And one of the biggest things for our patients, especially somebody like ours, is immobility. And so whether it's prolonged ventilation, if somebody comes in with sepsis, ARDS, and they also have drugs on board, such as neuromuscular blockers, immobility can result in something called mechanical silencing, which basically leads to disuse atrophy. Other drugs, such as vasoactive drugs, necessary, especially for somebody who's in septic shock or some other process, can also result in, of course, microvascular issues with perfusion to things such as muscle and nerve. As we've briefly touched on, sedatives can also result in delirium and also more immobility as we go forward. The things that are non-modifiable but worth paying attention to are the severity of disease, patients with sepsis and SIRS, and specifically multiple organ failure as reasons why people are higher risk for ICU acquired weakness. And then additionally, finally, female sex, older age, and importantly, premorbid functional state are all important things to consider. If somebody comes in with lower reserve, they're much more risk of having continued injury and continued disability. They have less to pull from should something like this happen.
Yeah, thanks for walking us through that. It's an interesting spectrum to think about of the myopathy versus the neuropathy. I know we'll dive into it a little bit more. But just a word on the risk factors. It's always tough with the non-modifiable versus modifiable. One of the non-modifiables for the severity of disease, sepsis, how sick are you? And then one of the modifiables like vasoactive drugs, steroids, neuromuscular blockade, sedatives, and these sometimes can feel in practice sort of non-modifiable. You're like, this patient's really sick. I need to use 3 pressors to keep their map up. And so how modifiable is that? But I do think that it just raises the strong attention for us to have very intentional and best practices use when we're using things like adding a pressor, using neuromuscular blockade, adding steroids, sedatives for sure, right? It's like, does this person really need to be on neuromuscular blockade? Do they really need to be RAS -5? Or is it something that makes it easier for us, but is not necessary by their condition? So I do think, and we'll get into prevention and treatment, a lot of this is just being really mindful and really thoughtful about how we use these things, which is not easy because we're also trying to treat this critically ill patient. And so it takes a lot of awareness as we're going through it.
Totally, Bert. Thanks so much for bringing that up. And Jim, some great walkthrough of some pathophysiology. And I think that was such a great point on the risk factors, right? Coming back and bringing it back to our patient's case, as Kalaila mentioned, right? We had a 65-year-old gentleman admitted for 2 weeks in the ICU with severe sepsis, received corticosteroids. So exactly, it's like what's modifiable and what wasn't during his 2-week stay. Jim, so I would love for you to extend on 2 broad topics, which I think learners would probably really want to hear more about, and myself as well. So you mentioned that ICU-associated weakness encompasses both critical illness myopathy as well as critical illness polyneuropathy. You talked about the pathophysiology and the difference between them, but clinically, how can we distinguish between them, and how does that affect your overall management of the patient?
Absolutely. And also just a quick point on you talking about what is modifiable and what isn't modifiable as far as the Cape Cod dose steroids too. There's been some discussion of, is steroids actually a real risk factor in these cases for ICU acquired weakness? Are these people just sicker? Do they need steroids? And is this just a demonstration of where they are? And so going into that additionally, so talking about how we differentiate these people, I think the important thing is then getting into the why, right? And so critical illness myopathy versus neuropathy. The issue, as we were talking about before, being in the muscle or in the nerve, or in the joint, critical illness neuropathy, or radicular neuropathy and myopathy, some combination there. And so as we talk about something, an injury within the muscle, you talk about pure weakness, no sensory loss. And that's going to be one of the biggest differentiating factors between the two. But this one also happens more rapidly. You can have some muscle loss within the first 48 hours of ICU stay. You can have up to 2% of lean muscle mass loss per day for the first 2 weeks in ICU stay. So you really see a profound loss of muscle. And that's visible, something that you can physically see, which can help point you in those directions as well. With our patient, there's a slight elevation in CK, of course, not to a rhabdo level, but it also suggests that there's some level of muscle damage happening as well. For the neuropathy, of course, you're going to see damage to the entire nerve, not just a motor nerve. And so you're going to have sensory impact. As I started to allude to in the last part, you can also differentiate where the injury is based on the location of presentation. So if there's more distal predominant weakness, which is not common at all in critical illness myopathy, but would potentially be more common in something of a critical illness neuropathy picture, because of the length of the axon itself, the more time in which, or more space in which this nerve has to be injured. And so those are some of the big, important differentiating factors in general. And then for the critical illness polyneuropathy and myopathy, the combination ended up being very murky, as Dave was talking about earlier in this, where you can have a typical presentation, and then somebody who comes in with a presentation that looks like it's very different than what you're taught in the book. And so that's how I think of the neuromyopathy picture.
It's great. Thanks, Jim. We're trying to really put on specific labels to something that is often a hybrid, often difficult to distinguish. I think this is important both for treatment, but also for like ongoing research, to understand what the condition is and to name it appropriately, even though out of practicality and convenience, we often will use an all-encapsulating term. So for this, as we've mentioned, we've ruled out major things we sometimes think about in the ICU: new ischemic strokes, new hemorrhages. As you mentioned, and we didn't have an EEG yet, but let's assume we got one and we didn't have seizures, and weakness would be very atypical for that. We've ruled out encephalitis and meningitis. Also, for the sake of argument here, let's assume this is not a myasthenia gravis, Lambert-Eaton, organophosphate poisoning case where something was missed, and in some cases you'll have the testing for that, but it didn't seem typical. If we want a sort of diagnostic purist as opposed to diagnostic nihilist for this one, Kalaila, what would we do? What tools could we use to clinch the diagnosis and feel pretty comfortable calling this this umbrella term of ICU acquired weakness?
Yeah, so there are a couple of tools that are commonly used. The most commonly used one to make a diagnosis of ICU acquired weakness is this score called the Medical Research Council score, or the MRCSS. And basically what that is that we as physicians will grade 12 different muscle groups and then tally up that total score. If the total score is less than 48, then we think about someone having ICU acquired weakness. And if it's less than 36, we think of it as a severe disease. There are a couple of other scores like the Critical Care Physical Assessment Tool or the Functional Status Score for the ICU. These are also just ways to assess someone's functional mobility and cadence and ambulation, but they're less used than the MRCSS. And then we have something called a handheld dynamometer, which is supposed to be a screening tool. And basically what that is that we will assess the maximum exertional strength that someone's grip strength. And then if it's less than 11 kilograms in men or less than 7 kilograms in female, that's a very good screening tool for someone having ICU acquired weakness. I think the caveat with all of these is that the patient should be awake and able to cooperate with an exam. And we know that oftentimes our patients in the ICU are sedated or delirious, and we've talked about that a lot. So we have a couple of different things we can do outside of these scores. So we talked about imaging, maybe a muscle ultrasound. These are good because we can do it at the bedside repeatedly. The problem with it is that it sometimes underestimates muscle loss in a patient, and especially if they're really edematous, I think it's a little bit harder to get good windows. We can do other imaging like CTs or MRIs, but these are expensive, and oftentimes it's a logistical challenge to get them all the way down to the CT scanner. The two gold standards for defining ICU acquired weakness are the electrophysiologic evaluations and the muscle biopsies. So the electrophysiologic evaluations consist of nerve studies, nerve conduction studies, and EMGs. And these are great because the patient doesn't have to cooperate with them. But the problem is that they're time consuming. There is a little bit of pain that may be involved, a little bit of invasiveness. And usually the technicians have to be trained, and we need trained physicians to be able to interpret these studies. And then the last one, the other part of the gold standard, is a muscle biopsy. And this is really great because we can actually tell the difference between critical illness myopathy and polyneuropathy and whether it's a combination of both. But of course, it's invasive, and we have all of the risks of a procedure like infection, bleeding, et cetera.
Yeah, this diagnostic portion is so interesting. As you said, there's some really great tools if your patient is awake and cooperative. And so that happens. And that patient has gotten better. They can participate. They can do some ventilator mechanics. They can use the dynamometer. I probably mispronounced that, but dynamometer, right, to give us some hand rim strength. But a lot of our patients are not in that case. Going all the way to muscle biopsy then sometimes feels like a lot, right? I have personally had EMG come in the ICU, and I've actually found it pretty helpful. The patients I've had it the most is when the history is a little murky of how they've been doing at home. Obviously, we have a large frailty population in the ICU. And so sometimes there's just well, they haven't been doing so well. Maybe they have been weaker at home. And then you're wondering, was there this precondition? As Jim said, ICU acquired weakness can layer on top, but it really shouldn't have preceded the weakness shouldn't have preceded the critical illness. And so I have had that EMG done to help say, look, there's not some isolated muscle problem. There's not some isolated neuromuscular problem. This looks like we have now this combined polyneuropathy, myopathy. This is just going to take time. And that's influence decision making, right? Giving me a better sense of how I can, what course I can anticipate. Does this patient want a prolonged rehab course? Do they want a trach? Things like that, where we have a little bit more diagnostic clarity. And then it could say, look, if this is pure muscle, then maybe I would do a muscle biopsy. The only caveat I'll also add, I am much more in the diagnostic purist camp. I love to really know what's going on, but I've gone through the whole pathway, gotten EMG, gotten muscle biopsy, and still people are well, I don't know, maybe it's a little diabetes, maybe it's a little critical illness, or it's not always you get a crystal clear answer. So you have to decide with your patient and their family how much that's worth it to you. Jim, anything to add about that diagnostic process?
Yeah, I think, and thank you. This is such a, I think, important part of the conversation. I think, as we've talked about before, as far as prognostication, the diagnostic purist in me really wants something like this. I think EMG is something that is incredibly helpful in these cases. The issue, however, is EMG, whenever you ask for it, they also push back because there's electrical interference with all the ventilators and everything else. And so it makes the test that much more murky. And so as far as, in a perfect world, we have a lack of electrical interference. We can get this handheld thing because the EMG machines are massive, tough to bring into already crowded rooms. But as far as talking about what the patient can expect and having those really important family conversations, patient conversations, what do you want going forward? What can we tell you this is going to look like? We've talked about the differences of myopathy versus neuropathy. One important difference that I forgot to include is the myopathy tends to have a better prognosis. You have a much better ability to rebuild muscle than that of nerve, especially because nerve, it takes time, much more time. There's Wallerian degeneration. There's time equivalent to the distance that it needs to travel to recover, and then is it actually going to recover? And so being able to differentiate via something like an EMG, more so than a muscle biopsy, because that tells you there's myopathy, but it doesn't tell you the lack of neuropathy. And so importantly, the EMG, you can actually differentiate, is this a myopathic pattern, or is this a neuropathic pattern, or is this both? So if you're able to do that, you can have really informed conversations with the patient and the family going forward about what to expect as well.
Thanks so much, Jim. And as you're saying this, and I have another question for you as well that I love your expertise on, because I think even just between institutions, there's going to be variation in what type of tests are available. I know it's quite difficult to get EMG in many of our ICU. It's not impossible, but it does take some logistical planning. But I'm wondering, for those institutions or places where EMG is not going to be readily available and the patient's not alert and can't cooperate with like the screening tools that Kalaila mentioned and some of the other things, where are you left at with that if that's not an option for some patients?
As far as trying to differentiate between ICU, the critical illness, myopathy, neuropathy,
Yes.
Then you really get into a murky space. I think it's still in its infancy, but as far as looking at muscle ultrasound, there are different grading scales that can be helpful. But as we've already talked about, there's a lot of differences as far as intubator reliability and somebody who's edematous because they've been in the ICU getting fluids, and any other number of reasons that can be an issue. You can clearly see, and if you do an ultrasound once a week on a patient, you can see that there's a change in the architecture. That's something that's pretty clear there. But as far as ruling out a nerve injury, that's really, really hard. And so it gets difficult on that. Ideally, that's potentially something that then can get further elucidated down the road when you're out of the ICU or you've gotten a trach and a bag and you're more on the rehab side. So the conversations can continue. It doesn't, ideally, of course, and as intensive as we want to have everything laid out, this is where we go from here. This is what's going to happen. But this, as we've all alluded to quite a few times, becomes quite murky.
Yeah, thanks so much for that. And Kalaila, I'm hoping we can come back to the patient that you presented and tell us what type of diagnostic test he was able to undergo and the plans from there.
Yeah, so he actually was able to cooperate with our exam. He scored a 32 on the MRCSS, so that is severe ICU acquired weakness. And then he did the handheld dynamometer, I'm going to say it wrong too, dynamometer. And he also had a poor grip strength. So overall, we think severe ICU acquired weakness.
Yes, I think we confirm that we fall squarely into this umbrella term. Big question is now, what can we do about it? Patient already has it. And so what are the types of interventions or things that we can do to help them recover? And then obviously we also want to keep in the back of our mind things we can learn from this patient to treat the next one to maybe see if we can try to prevent this. So Jim, anything, treatments or best practices we can do for patients like this?
Yeah, absolutely. And so, as you've alluded to, this person already has this process. And so, as with anything, the best treatment is prevention. And so an ounce of prevention is greater than a pound of cure. However, as I think the important thing is realizing that this is a process that can continue to happen. And so by doing something now, you're also stepping in and preventing worsening of it. And so in general, I like to think about two different kind of acronyms for thinking about it. One the factors that are associated with this increased weakness and trying to simplify it for myself, because we've talked about things in depth and there's quite a lot. So if you're thinking somebody has or is at risk of ICU acquired weakness, things that you want to think about are sepsis and inflammation as risk factors, immobilization and inactivity, and resource imbalance, whether that be hyperglycemia, hypoglycemia, mitochondrial dysfunction, ATP depletion, any other electrolyte abnormality, hypermagnesemia being a cause of weakness and things like that. And then exogenous things for the E. What are we doing to this person that we can potentially try and pull them? Limit neuromuscular blockers, limit corticosteroids, and then thinking about maybe the vulnerability that you've already talked about. What was this person doing before, and how can we best tee them up? And then thinking about our patient and what we do, you want to treat the infection. We gave compound dose steroids, we gave antibiotics, we gave everything that needed to be done to treat the underlying process. Another thing, I'm glad that we talked about kind of Wesley and colleagues as far as the ADF bundle. This is something that has been really impactful for a number of different processes, critical illness, and looking at different outcomes, not just weakness. But this is something that, for those who are not familiar, the ADF bundle is a collection of 6 different interventions that can be and should be done for every patient every day. Broad strokes talking about choice of sedation, daily SAT, SBT, assessing and managing pain, delirium treatment, and then importantly, early mobility. And so I think on my own little soapbox, I think early mobility is also a little of a shortcoming going forward too. You get early mobility that just talks about walking. We can also start talking about what we can do with the patient in the bed, yells and things of that nature. So trying to get people involved and engaged to kind of help their function either improve or stall the downtrend in function. And then of course talking to families, which is something that's very important. And we already talked about as far as controlling glucose, pretty important. And then team-based care. We want to make sure that everybody who needs to be involved is involved, whether it be therapists or different consulting services and things of that nature. So just really being very vigilant and trying to prevent any worsening and recognize the warning signs. One last thing that's based on different meta-analyses and reviews that can potentially be helpful, but is not yet. And it's actually in the recommendations for any ICU that can feasibly do it is NMES, or neuromuscular electric stimulation. This is helpful for, as we talked about, all the patients who we have who are intubated, sedated, unable to participate in things. NMES places electrodes on the muscles and causes contraction. So there's improvement as far as lack of mechanical silencing, engagement of these muscles that can potentially prevent this myopathy, or at least atrophy and weakness part. However, other things associated with critical illness end up being things that really limit the efficacy of this, because if you're septic, acidotic, the stimulation needed for contraction is also higher. And so in general, it's something that potentially could be helpful if your hospital is proficient and able to do it.
Great. Thank you so much, Jim. And I know, as you mentioned, so important, prevention is key. But if you have this, right, there are many steps that you can do to try to prevent or minimize the outcomes from it. So I know I have the opportunity to work with Del Needham, and early mobility is definitely something that we try to do. And I know sometimes when we're rounding in the ICU, like we're coming to the end, and everyone's like, well, what would Del do? What would Del say for this patient? Because if Del says it, we got to do it. But definitely so many great things and so many colleagues to get to work with to help patients with ICU acquired weakness. And Kalaila, I think we're coming to an end on our case. I would love if you can give us an update in how the patient was managed and overall outcome.
Yeah, of course. So he underwent aggressive physical therapy. That's to prevent any further muscle atrophy, improve his strength. We did a better job with controlling his sugars with his insulin sliding scale, and we were able to start him on enteral nutrition very quickly. Fortunately, he had already completed his dose of steroids, so that kind of out of the way. And ultimately, he was transferred to an LTAC. And then after being there for several weeks, he was actually able to improve enough that he was weaned off of the vent successfully.
Well, that's so great to hear. And I know definitely, I think all of us that take care of patients in the ICU, a lot of the courses can be quite long and extend outside the ICU to the floors as well as to rehab facility. So definitely a long process and a lot of people that help along the way. And I'm glad that he had a successful outcome. Well, I know that Dave and I really want to thank you both for joining today. This has been a great case and a great topic to introduce. So thank you so much, Jim and Kalaila, for being with us here today. Jim, just wanted to see if you had any parting words for today or anything that you wanted to add.
Yeah, so I think, first off, I want to thank you all for allowing me to be here. It's really been a pleasure and really just a lot of fun to talk about something that is really important to me. This is something that I plan on spending a lot of my career looking further into. And so having the ability to be here and talk with you guys has been a lot of fun. I think as far as a takeaway goes, I'd say be vigilant. Know that this is something that not just can happen, but does happen frequently, and to know the warning signs and how to intervene.
Kalaila, thanks, Jim. It's great. Kalaila, did you have any takeaway points or anything that you wanted to add from this case?
Yeah, I'd say a takeaway point for me is what you were mentioning about how sometimes even the things that we're doing don't feel like modifiable risk factors. So really just keeping a very close eye on what we're giving the patients and what we can pull back when we need to.
Yeah, 100%. I think that is attention to detail of these things. And I have also had the pleasure of rounding with Dale, Christina, and I think he is a prime example of things are modifiable, even though we are getting entrenched and think they're not. And beyond just him, but everywhere, I think the best case scenario for this story is the use of midazolam and benzos, which we know are associated with worsened delirium and outcomes. And really, this was super common practice basically everywhere. And now very, very rarely are you going to see people on sustained drips at high doses unless there's like absolutely no other option. So it just takes time. I think my takeaway is going to be something Jim was talking about with the spectrum, critical illness, myopathy to neuropathy, and then the mix. In my own entrenched frameworks, I usually think of ICU acquired weakness as muscle alone because I'm really thinking about that early myopathy. But it's important for me to always remember that you can get these sensory deficits that come on later on, and then you can get this more sort of mixed picture. And I know that, and I've seen patients with that, but it takes time to build into my illness script for ICU acquired weakness. So that's one I'll add to it. Christina?
Awesome. Yeah, I think I'm going back to one of Jim's first things that he discussed when thinking about ICU acquired weakness, really more of this umbrella term. And then I think a nice point that was mentioned was weakness must not precede critical illness, and how we think about that. So that's one of the many takeaways from today.
That's great. Well, thank you guys again for coming on the show. Thank you all for tuning in and listening. Stay out there, be vigilant about these factors and screening for ICU acquired weakness. And tune in 2 weeks for our next episode. This episode was written, produced, edited by myself, Christina Montemayor. Kalaila Pais came up with the idea, and Jim is our expert consultant here. And the music is original music by Eric Rogers. And we'll see you next time.